radar. And I can see that Dr. Bostom is trying to get his audio connecting to us. And yes, Dr. Bostom, how are you?
Good. How you guys doing?
Good. All right. Welcome back to our show.
Welcome.
Good to be with you guys again.
All right. So two things we want you to comment on.
Yeah.
I don't know if you just saw this. So we just shared this with our audience. The governor announced 7 new restrictions on our lives today, from sports to family gatherings to travel to box stores to, and she even talked about a curfew. We now have a curfew, 10 p.m. to 5 a.m. Not going to fine us or punish us yet, but that could be coming. I mean, trying to control every aspect of our life. And then earlier this week, she announced that if somebody in your close circle tested positive, no more 14-day quarantine. Now we need you to quarantine for 10 extra days, 24 just to be sure. Stay at home, stay away from work, don't do anything. Is there any data, doctor, nationally, locally, to support this kind of theory?
Absolutely none. It's the opposite, actually. First of all, they're always getting at this idea of asymptomatic transmission and going all the way back to the beginning of the pandemic when it was, it was frankly much more lethal than it is now. Study out of Singapore showed that and this was published in Morbidity and Mortality Weekly Report, which is really a CDC journal. It's published by the CDC, and they found that there was essentially no asymptomatic transmission, at least in their hands. A contemporaneous study around the same time out of China actually looked, well, what happens when you test asymptomatic contacts of family members who are known to be positive and clinically ill to a certain extent, at least. And they found that if you test the contacts, you get a false positive rate of about 75%.
Wow.
And
false
positive rate. If they're asymptomatic, even though they've had a potential exposure by being with someone who is positive, and if you use that as your criterion for testing them, that there's a 75% probability for a false positive rate. Now you can argue, well, this is at the beginning, maybe the testing wasn't so great. Fast forward to now, and we've got an analysis of a whole series of studies done out of Oxford. This is something called the Clinical Evidence-Based Medicine Consortium at Oxford. Very prestigious, very hard-nosed guys that are clinicians and investigators, mostly family practitioners, or the equivalent in England, internists, but they are evidence-based people. They reviewed all the data where you compare the standard testing, which we talked about last time, Mike, with the idea of a cycle threshold at which it tests positive. It's something called rtPCR. They looked at a whole range of those studies, at least 10, and your ability to actually culture virus. And what they said, because culturing virus means infectivity, having virus present. So
and growing
it out. What quote from this pooled analysis of at least it was actually 9 studies. Infectivity declines after day 8, even among cases with high ongoing viral loads, so probably low CTs. A very small proportion of people retesting positive after hospital discharge. So these are patients sick enough to be admitted to the hospital or with high CTs, those that have very low viral loads, are likely to be infectious. So this is
24 days of quarantine.
This is what you're getting. And again, the reason that our public health officials and the governor get away with this is because there's no transparency. As I mentioned last time, we've had what is it, Mike? I didn't look at the site today. I think we're close to 40,000 positive tests in the state. We should have.
I'm going to share the screen as you talk. Go ahead.
We should have the cycle threshold distribution for the entire population of positive tests that have occurred in Rhode Island. We should know the percentage that were less than or equal to 20, 21 to 25, 26 to 30, 31 to 35, and above 35, because certainly by the time you get above 30, absolutely, by the time you get above 35, the likelihood is that these people are not the least bit infectious. And interestingly, Mike, this is really important. So the Democrats' demigod on COVID-19, Dr. Fauci, in an interview on a podcast about virology. So it's a very focused podcast where he's not into BSing, he's just giving data. He said, if you get a cycle threshold of greater than or equal to 35, the chances of it being replication competent, he means infectious, are minuscule. He went on to say, you almost never can culture virus from a 37 threshold cycle. If somebody does come in with 37, 38, even 36, you gotta say
so what
it's
you're
just
saying,
10 nucleotides, period.
So can I try to translate to see if it's, you're the doctor here and you talk words I don't understand. So you're saying there are different levels of infection, and the cycle threshold, I'm putting it in layman's terms.
Yeah.
Tell you whether you're at a level that's infectious or not, right?
Mike, it's a darn good surrogate for that, other than taking every person and saying, well, we're gonna have to wait 3 weeks and culture out your virus.
Yeah, treating every person like they got deadly Ebola or something like that.
Well, it's a quick way to get a sense of how much virus, using the standard testing that they're using, the swab tests, the saliva tests, etc. And what Dr. Fauci was saying back in mid-July, was that certainly above 35, there's no evidence that these people are infectious. And so what I'm saying is the transparency has to be that personally, everyone who is tested by RT-PCR should demand the cycle threshold. But more importantly, the state has thousands of tests. What is the distribution of the cycle threshold for the people that they're testing? Do it weekly. They tell you the positivity per week. This week, the last week that they reported for the 7-day period, it was 3.3%. So it had gone up from 2.9%. I still think that's pretty modest compared to the almost 12% that we had in the spring. But each week, what is the percentage that are occurring at these low, medium, and high cycle thresholds? There's no reason they couldn't do that. And that would be a transparent way. Look, if the whole distribution starts to shift towards the lower range of cycle thresholds, then I think that is cause for being more vigilant.
Mike, got a question for the doctor?
No, I'm soaking this all in.
All right.
You know,
So doctor, the lower the threshold, your cycle threshold, the more infectious you are.
Yeah, in India they do it very simply because they have 1.4 billion people and they have to marshal and triage their resources. And what they say is, if you're above 50 and you may have a comorbidity like diabetes or coronary disease, if you have a cycle threshold of 20 or less, they want to see you. As a matter of fact, they may electively admit you for observation. If you're 21 to 25, you can stay home and be in touch with their equivalent of nurse practitioners, etc. They don't even talk about above 25.
Now that sounds like a scientific, data-driven approach.
right.
It's also a medical triage approach because they don't have the resources that we have in a country like the United States.
Doctor,
but still, it's the same principle.
Doc, if you can break it down for me for a second. When you say the cycle count, is that like a bacteria count or something? That number you're driving?
It's actually a surrogate for the virus count.
Okay.
Yes.
Okay.
Because what it's telling you is that the fragment of the virus's genetic code, in this case it's RNA, that they're amplifying can be amplified to a detectable level at a lower cycle threshold, indicating more virus to be able to do that.
I got you.
So for example, when you're a cycle threshold positive at 12 on this major assay that's used in the Northeast, you have about 2 billion copies of the virus equivalent. By the time you get up to 38, it's down to 8. So it's literally a 250 million fold range.
Wow. So are the tests we take today, either the rapid test or the nasal test that they send out, do they measure cycle?
Yeah. Well, so what they've been doing on the campuses, for example, is in some cases they were using a non-RT-PCR test as a screening test, something called an antigen test. But they would only start their restrictions on these kids when they confirmed it with the PCR test. And most of the platforms that are doing the PCR testing have a cycle threshold available for each test. Now, Mike, what they say, and again, this is just anti-transparency. It doesn't make sense scientifically. Well, our emergency use authorization for the RT-PCR testing only said positive or negative. In other words, it didn't, even though we collected on every single test, it didn't approve us to release the CT data. That's baloney, because they're setting the cycle thresholds according to the CDC up to 40. So in other words, if you test anywhere up to 40, you're positive. So that's a decision that was made, and it's based on the cycle threshold. The cycle threshold is what's determining where you become positive, and they're routinely recording it. So it's horse crap to say that they can't release that information. And in fact, going back to India, a lot of the physicians, the pulmonary docs, the general internist equivalents, told the companies that no, they want that data for the physician and for the patient. So a lot of the big labs.
So you're saying our state has this information?
A lot of it, and in fact, I know it's being FOIA'd.
Are there any states that are releasing this information?
No, because it's not being demanded enough by the public. It's being released for, quote unquote, research purposes in some cases by labs that are working with universities. But it's all subject to FOIA, and I can tell you there are FOIA requests in, but the state is being very obstructionist about it, and I can tell you charging fees.
You work with Judicial Watch on this, right?
That's right. So I can say that a FOIA request is in with Judicial Watch, and they're charging a large fee, and probably it's going to have to be litigated, or something else, or maybe we can get
trying to
local.
discourage you from having it by hiding behind a big fee.
Yeah, but maybe we could also get local legislators in the state Senate or the House to demand this information.
All right, so to
it's
wrap this
ridiculous
up,
that the state should be charging money to release data. Look, I'm not saying they have the cycle threshold data on every single test in the state. Obviously,
there's a lot
of them.
We have a good sample, I'm sure. So
Absolutely.
Let me wrap this up, and then we want to get to a caller on another topic. I promise not to keep you long today. So to wrap this up, there are different levels. I'm putting in total layman's terms. There are different levels of infection if you test positive, and at many of those levels you're not infectious enough to be a spreader, right?
What I would say, Mike, there's a good enough body of literature now to make those inferences. In other words, going from the cycle threshold at studies which included your ability to culture the virus and extrapolating it to clinical situations, and there's a broadly emerging consensus now. Some would argue more conservatively that if it's above a cycle threshold of 30, others might say 33 or 35. But certainly by the time you get above 35, again, the Democrats' demigod on COVID-19, Anthony Fauci, says above 35, it's quote unquote dead nucleotides.
Yeah, okay. So, all right, you've given us, now I get it. And so again, nothing would justify these statewide bans on going to kids' games, the 24-day quarantine.
The 24-day quarantine
curfew
makes
at 10 p.m.
Mike,
does the cycle threshold go down after 10 p.m.?
Yeah, right. Mike, the 24-day quarantine does not fit in with the clinical literature. It really doesn't. And you can argue, well, when they were doing some of the early studies, maybe they didn't have the best assays, but they were still looking at the patients clinically. And they weren't seeing, and again, going back to Fauci argued that coronavirus, like other respiratory viruses, the spread, certainly the epidemic spread, the wide outbreak spread, is driven by symptomatic people. That's just the way these things operate. So to be penalizing people who probably have very high cycle threshold positives, which are of dubious meaning clinically and in terms of their infectiousness is just uncalled for.
Dr. Andrew Bostom, a Brown University credentialed epidemiologist and
Mike, can we-
nationally known. Thank you. What, do you have another question, Mike?
Well, just a statement. Is there any way we can reach out to some of our people to help them with maybe some of these FOIAs?
Well, they've got the best in the business going on with the judicial watch.
Yeah, it's really a question of waiving the fees. I mean, it's just, it's unbelievable. And I guess look, I'm not a lawyer. I guess there's some case law which says they really shouldn't be engaging in practices like this. Like on the other end of the political spectrum, the ACLU has been very successful in saying, you can't charge for this information. It's just not right. And they've successfully litigated. So
yeah, that's a whole other question as to whether or not we can, that's their way of. Well, they say they're the most transparent governors
Well, they
in
hide the
state's
data.
history, but they hide behind these. He's in hiding behind COVID now, saying, oh, because of COVID, it's going to take us an extra 3 weeks to process your Anyway, Dr. Boston,
Thank you.
great
thank you.
feedback.
Great
I hope you'll come back again.
anytime.
We want
thank
you to be a
yeah.
regular on this.
Oof.
Have you ever contacted the state officials yourself?
Yeah, I have. My local representative out here in Gloucester. There was just a state senator that was elected. I'm thinking of contacting her too. I'll keep pursuing it.
All right.
And
Well, we want to give you a platform if you don't mind. If that's okay.
Jessica Dela Cruz, right?
Yes. Jessica Dela Cruz was just elected. Mike
Yeah, she's
Chippendale
terrific.
was reelected. So
Gordon Rogers up that way, and Jessica, they're both.
Mike Chippendale, I think he's actually in Chippendale.
I've been in touch with Mike. Yeah, but I just think that if they can help, sure. But the bottom line is, I don't really. It's not like I want to do research with it.
Right.
I mean, frankly, I would just like to see it posted simply the way I described it. The typical graph that you get of other data that they have on the Department of Health website. It's like a bar graph. Okay, well, here's the spike for the people who tested, less than or equal to 20. Here's the group of people who tested 21 to 25. Here's 26 to 30. Here's 31 to 35. Here's above 35. Just graph it for us. Show us.
1 second, real quick, Dr. B. When they test people, are people able to get their number?
That's no one knows to ask for it. No one knows to ask
Maybe we
for
need
it.
to start a campaign to ask.
Yeah, should we educate the public on it?
Absolutely, because I can tell you
Great point, Mike.
that one of the biggest platforms in the state at Lifespan, they have it for every single test.
Then that's what we.
Now, they're going to tell you, well, we're not allowed to release that because our emergency use application.
That could be the basis for a lawsuit. My liberty should not be restricted because I'm not a problem.
There's a logical flaw to that argument. The CDC has regulated these assays and told them that they should run them to a cycle threshold of 40. Well, how do they know it's a cycle threshold of 40 without having the cycle threshold? So and of course they routinely record where it becomes positive.
But what determines positive? What cycle threshold determines positivity? You have to measure.
Well, they know when it
Makes sense.
becomes positive. But what I'm saying is the arbitrary decision has already been made that positivity is based on becoming positive within 40 cycles. So it's BS to say that the emergency use application doesn't cover that. It's an arbitrary decision. You have to decide it's positive.
Wow, a lot to think about. All right, Dr. Boston, thank you very much.
Thank
Good
you.
day. We'll have you back soon.
Bye.
Wow, Mike.